Welcome everybody to the Southeast Asia SIB webinar. Thank you very much for making the time to come today. I really appreciate, I know how busy everyone is working on projects, so I appreciate everyone sort of taking the time. It should just take an hour, but hopefully in that time we'll be able to hear from a couple of our Seeing is Believing project managers about some of the ways that in their projects they've strengthened the eye health system. So again, thank you very much for coming and a warm welcome. In terms of our presenters today, I'll just want to also welcome and introduce our presenters. So most of you know Sally Crick, who's the Seeing is Believing Programme Manager. She's just going to do a little introduction in a little bit. And then we've also got Pratik Gupta, who's the Regional Advisor for Helengkala, Indonesia. We've also got Ravi Gautam, the Senior Monitoring and Evaluation Officer for Tilganga Institute of Ophthalmology for the Nepal Eye Programme in Nepal. So welcome to all of you. Thank you so much for presenting on the first sort of Seeing is Believing webinar for the Southeast Asia region. Really appreciate it and the effort that you've put in to kind of work on your presentations and, you know, to be happy to share some of your learning with the rest of the Seeing is Believing projects in the Southeast Asia region. In terms of the agenda, so as I said, we're going to start, Sally's going to do sort of a brief introduction, then Pratik's going to do his presentation on strengthening eye health systems and how the work that they've been doing in Indonesia is doing that. Then Ravi will do the same for the project in Nepal. Each of those presentations will take sort of 10 to 15 minutes. And then there'll be a question and answer session at the end. So over to Sally for our introduction.
Great. Okay. Hi, everybody. I can see there are 23 of us on this call now. I'm very excited that Seeing is Believing has started these webinars. This is our second one. We had the Africa one last week. And today we've got two new panelists to continue our theme on the sort of health system support that the Seeing is Believing projects are able to offer. I won't sort of take up a lot of time, but except just to say, first of all, big thank you to Susan, who has been the organiser with a bit of help from London School here for these webinars, and we're really excited that we've got these off the ground. Sorry for any hitches and things. We're on a sort of steep learning curve here, but it seems to be going really well, and I'm really looking forward to today's event as well.
Thank you, Sally, for doing the introduction. And Pratik, can I now hand over to you for the first presentation?
Thank you so much. Really appreciate the introduction from both Susan and Sally. And so, yeah, as mentioned, I'm representing Helengkala International in Indonesia and our team that's been involved with the Refractive Error program. We've received funding from Seeing is Believing since 2009, and we've had a chance to screen quite a few children, almost maybe 300,000 children since 2009 in Jakarta and in the East Java area for refractive error. And so I'm going to be sharing results from our most recently completed project that extended from 2012 to 2015, and just some thoughts in terms of how it can be related to overall health systems delivery. And I look forward to receiving any questions after that. Next slide, please. So just to read off from this first slide, our objective for refractive error was to improve the vision of adolescent students, teachers, and adults in Jakarta and the surrounding area by establishing school-based, community-based systems for identifying uncorrected refractive error, providing free or low-cost corrective eyeglasses, and referrals for further examination and treatment prior. So just to give a sense of where at least our main target audience in Indonesia, our target population, we target children that were between the ages of 11 to 15. refractive error among children is anywhere between 20 and 30%, and it has some geographical variation. Our process involved initially a school-based screening program, and so as you see on the projector screen, it went through a series of steps. So first, we trained school health unit teachers to provide accurate visual acuity screenings using the Snellen chart. And so this was a pass-fail measure to see if a child needed to be refracted. And so the teachers could do that to all of the students in their school. These teachers, once they were trained, they performed the visual acuity screening and they recorded the results of the children that failed the screen using the Snellen chart. And so then what they would do is the school would inform HKI of the results, and HKI had staff refraction opticians who would then go to the school and refract the children for glasses. So that's the next step of this team of refractionists would visit each of these schools and specifically those students that failed the visual acuity screen. And then during this process, those children that failed, if they needed glasses, they were given an option to choose from about 8 or 9 different frames for their eyeglasses. So some of them could be fun colors like red or black. And then we would prepare the eyeglasses. Sometime within a few weeks after the refraction, we would have a distribution day where the students would receive their new eyeglasses and their visions were tested again with these new eyeglasses to make sure that it was 20/20 or 6/6. We collected data on a routine basis on assessing how well the teachers were screening, as well as understanding whether the children were complying with wearing the eyeglasses on an annual basis. And then, as part of the sessions, we provided a lot of education with the students to make sure that it's important to wear your glasses, to wear them at all times. And then we used this to advocate with the Jakarta provincial government to support the program, to say that you have a lot of children that need eyeglasses, there's not a lot of them that have the glasses, and you have this opportunity through your school, which has a mandate to provide some health services, to do some sorts of routine screening. And so this was all part of the chain. Next slide, please. So this is just more of a conceptual framework in terms of how we would go about our process. So we would first start with mapping and socialization. So this would be mapping the schools where we would be providing, which schools would we would conduct the screening at. During this project, we selected the schools at random. So there were, I think, about 250 schools in Jakarta, and we chose 140 of them at random to conduct the screening. And following that, as I mentioned, we trained the school health teachers. They then conducted the visual acuity screening, which was then followed by refraction conducted by the HKI staff refractionists, who would then distribute the eyeglasses or refer if the child had a more serious eye condition requiring some additional care. All throughout, there was compliance monitoring that helped us develop some of the communications materials that we included with the education. Where I think it's important to sort of focus in on that is that there are a couple systemic elements. Is that we had these schools. The schools had the teachers who have a mandate to provide some sort of health services, and so we worked very closely with the provincial government and the Department of Education in Jakarta to identify the schools and make sure that the right people were notified about the program. And so we thought that was really important. But one of the components, which is the actual refraction itself, was being done by Helen Keller International staff refractionists. And so that, I think, was maybe perhaps a little bit outside of the system in terms of providing service delivery. Next slide, please.
That's very honest.
So just to share some data over the 3 years of the screening, we had 144 schools. So you can see we screened more than 90,000 students. 27,000 of those students failed the screening by the trained school health unit teacher. Of those 27,000 children, 23,700 of them were refracted. And there was a bit of a drop-off because when the refraction was being conducted, approximately 3,500 children weren't available on the day of the screening. So then, as you can see, out of the 23,000 children that we actually did conduct the refraction, 18,000 children received eyeglasses. And so the criteria for receiving eyeglasses is that you either didn't have glasses, or the glasses that you had weren't sufficient to get you to the vision, or your vision was worse than 6'9", and that made you eligible for glasses. So that's a pretty significant number. We'll talk a little bit more about it there. There were quite a few false positives, so you can see that approximately 8% of the children had normal vision, and so they didn't need glasses. 415 of the children needed to be referred to a higher level of service, so the health centers or the hospitals, because they might have had something. What I find particularly interesting is that we only see about, out of the 23,000 children, 2,700 of them had currently appropriate eyeglasses. So these were the ones that actually had glasses that fit. And 197 of the children refused eyeglasses. So you can see that a school-based program can address a pretty major need for children between the ages of 11 and 15 that we see Jakarta. And so so that's there. Next slide, please. So as I mentioned a little bit earlier in the framework, initially our program was focused on screening in schools, but what we wanted to start doing is to see if we can develop a more sustainable way of providing year-round screening that's more built into the system, and it's not reliant on HKI staff refraction opticians that are going from school to school. So what we started to do is we piloted to build the capacity of 5 primary health centers who would then be able to do some eye health screening and provide the first level of support for patients with eye conditions. And so as part of this training, we trained staff at the 5 primary health centers on how to train these school health conditions, how to identify and manage common eye health conditions, and then refer the more complicated eye health conditions to hospitals. The idea, I think, longer term would be that these health centers, if they have the capacity to provide eye health support, it would eliminate the need for an organization like HKI to have to come in with its own refraction opticians to the schools, as I mentioned earlier. Next slide, please.
Okay.
So, as you can see here, there were 5 health centers where we conducted services, and over the course of a little more than a year, we screened approximately 14,000. This is adults and children for services. Nearly about half, a little more than half of them were from one primary health center. We're using that one, and the Country 3, which is the last one, had 2/3 of the service delivery, is because those health centers were providing eye health care before, and so people had already known that that's what we received services. The other 3 health centers, Jatinegara, Johor Bahru, and Jakarta, the eye health services there were new, and so you can see that there's a lower utilization there as compared to the other 2. And that's because some people, it might be taking them some time to realize that there's eye health services that are available. And I think that that's an interesting observation, just to say that you want to create a communication strategy to let your community know, because you could potentially have quite a bit of utilization if you have the services. As you can see, also a little bit more than 60% of the clients of these eye health services were female as opposed to male. Next slide, please. So just to share some of the observations from our refractive error program for the school, nearly 30% of the children that we screen, they have refractive error. And of those children that with refractive error, only 10% of them approximately had adequate glasses already. And of the children that needed glasses, more than 40% of them had never used them before. We were able to demonstrate that school health weekly teachers can be trained to identify refractive error among children, at least to be able to conduct the pass-fail screening. One of the interesting things that we found in the secondary reanalysis of the data is that on a percentage basis, girls in Jakarta in the schools that we screened had twice the prevalence of refractive errors compared to boys, which highlights the need to perhaps consider more specific targeting to the different genders to see it, and to make sure that you're able to access or to deliver services to both girls and boys. From our data, we looked at it, the refractive error increases by age, so it was approximately 20% among 11-year-old children, and an increase of 30%, more than 30% among 16-year-old children, and 95% of the refractive error among children is myopia. Next slide, please. And so just to talk a little bit about the primary health center-based services that are there, we talked about, the 5 primary health centers. They screened about 14,500 individuals over the course of the year. Most commonly, these primary health centers see refractive error followed by cataract. What we did learn is that refraction services are not part of the regular services of the primary health center, as they don't typically have a refraction staff. And so what this then requires is that, in a normal situation in Jakarta, somebody would have to go to an optical shop as opposed to the public service primary health centers. And so the primary health centers that we were working with, I believe most of them had brought on a refractionist, and so that was able to help out with these services. And we were able to pilot some school-based training through the trained nurses of the primary health center. This could potentially be an effective approach for a sustainable school screening program if you're going within the primary health centers to have them train the teachers. Next slide, please. So those are just some of our initial, the initial presentation and some of our initial observations. We'd certainly be interested to hear if people had some questions or some comments about some of the work, and just things that I could clarify a little more. Thank you.
Thanks, Pratik. That was really interesting and sort of really, really kind of comprehensive as well. I'm just gonna pop you on mute while I'm talking. But thank you. That was really interesting, and really some of the things that really stood out for me was that the fact you've taken these stats and you're basically saying that you're finding that 30% of children have refractive error in your schools, and actually only 10% had the spectacles. Of those, only 10% had sort of spectacles that were appropriate. It's really an interesting way of kind of then using that to kind of do your advocacy with the Department of Education, who, as you say, have some kind of like health mandate as well. So I thought that was really interesting. And also then setting up those relationships between the sort of department or sort of the education schools with the kind of primary health centres as well was really interesting as well. So thank you, that was really comprehensive. What I might do is I might say let's wait until the end of Ravi's presentation as well, and then we'll take questions on both of the presentations, if that's okay.
Sure, and I just want to kind of follow up on your comment, if I could.
Please.
I think that where it's been really interesting is that when we are sharing this data of how many children that we're able to screen, how many children that have refractive error, and how many of them need glasses, I think that becomes very interesting to the provincial health departments and the provincial department of education. And I think that HKI, being a non-governmental organization, where we have a role to play is maybe to bridge between those two units, the health and education, in a way that we can share this information and share the information when they may not be necessarily talking to each other. And I think they're still trying to figure out how do you coordinate health services at a school. And so we think that this is we're going to continue using this data to share wherever we can, but we've been really pleased with some of the feedback we've received from the provincial district health and education offices in terms of them being really interested in saying, okay, well, we've got to do something about this. Thank you.
Great, thanks, Pratik. Right, Ravi, I'm just going to change over the slides and then, here we go, over to you. Right, slide from the beginning. Okay, so thank you, Pratik, and Ravi, over to you. So as I mentioned, Ravi Gautam is the Senior Monitoring and Evaluation Officer from Tilganga Institute of Ophthalmology in Nepal.
Hello, myself Ravi Gautam, and hello to all the 41 attendees there. I'm representing Tilganga Institute of Ophthalmology, Nepal Eye Program, the implementing partner of Seeing is Believing Phase 5 project in Nepal. So in first slide, we can see these are our major goals: to reduce the avoidable blindness by developing a surgical facility in rural and semi-urban areas. And here, the main objective of the project is to upgrade the existing community eye centers into achievable models for sustainable eye health care in rural and semi-urban districts. Next slide. Let us start background here. Tilganga and Nepal Eye Program has been working in community since 1994, and TRA is currently implementing the 5-year project starting from April 2014 to March 9, 2019. So we have our one existing CECs at remote areas, 2 different CECs. So these two district community eye centers provides basic refraction screening, spectacle and medicine, as well as counseling and referral services from these communities. But what this project assumes is these 2 district community eye centers will be upgraded into surgical facilities, building surgical facilities in form of secondary level eye hospitals. Next slide, please. So in Nepal is a major activities to strengthen the existing eye health system. We have outlined 5 different activities that are outlined as infrastructure development, service delivery, training and orientation, advocacy and awareness, and management and coordination. So under these various 5 different activities, we have other sub-activities that we would like to discuss. Next slide, please. Under the infrastructure development, we have 2 building construction projects where we establish surgical facility that will be equipped with periodic and regular service surgical facilities at communities. So building construction and equipment procurement are the major activities under this infrastructure development. Next slide, please. On the second major activity, we have service delivery section, where a number of services will be provided in the community. The project 5-year project assumes that above 6,000 cataract surgery will be performed in community, and we can also see the achievement by the date we have achieved. So 22% of total target has already been achieved by the second year of the project, and over 1 lakh school children will be treated and refer for other intervention. Similarly, 1 lakh above patient will be treated in the community to screen the patient and develop some program through surgical facility as well as refraction and medication. And at the established centers, in 2 community eye centers, there 1,28,000 above patients will be treated. Similarly, among that, 50,000 above refraction and spectacle prescription will be given to the patients. And similarly, 36,000 above spectacles will be distributed. And similarly, eye health information will be provided to above 55,000 patients. And among these patients, 30,500 above will be pediatric cases. So we have already crossed the second year implementation phase. So by this time we have achieved around 20 to 25% in most of the service delivery activities. In 2015 we faced a major earthquake that also disrupt or alter our some of the activities in community. So we see significantly low achievement in some activities here. So this backlog will be addressed with some strategic change that we have already been finalized, that I will share in upcoming slides. So next slide please. Third is training and orientation. To reach to community schools, we have an idea to train the school teachers from primary schools. So at the end of the project, there will be 750 primary school teachers trained, and by the time we have already trained 286 school teachers, so it's 40%. And to establish a good network and referral system, we have 3 training to mid-level ophthalmic personnel. These 2 training. This training will be conducted in year 3 and year 4. So this is on schedule. Next slide please. Okay, as a part of advocating the program in community as well as central level and increase the awareness among the people, we have 5 different advocacy communication program conduction plan in project duration. This assumes the World Sight Day event celebration as well as other facilitated meetings that will be conducted at the local level as well as in the central level. So by the time we have completed the 50% of the activities outlined under this activity. Similarly, IC materials have already been developed and distributed, and some are still ongoing to aware the community. So this is also one of the major program in community to aware the patient or the community through IC materials. Next one please. Just finally, for the effective implementation of 5-year project, we have various layers and activities to manage the program from program and finance perspective. So we have outlined 10 monitoring evaluation visits each year, twice, 2 times. So by the time we have completed 20 visits in district locations, and we will have a yearly financial auditing. So by the time we have already completed 2 audit program in community, and there will be 5 biannual and annual review meeting to review and plan for the successful implementation of these ongoing activities. And there will be a midterm evaluation on 2017, that's on schedule, and one final evaluation will be conducted at the end of the project to assess the overall impact in community. Next slide please. So in the earlier slide I discussed about the certain gap that backlog we found in our implementation phase. So these are some of the strategies that we have designed to implement in community for to meet the existing target as well as those backlog. So we have a strategy to include the private and government hospital schools to integrate into training as well as in school screening program. We are planning to mobilize FCSBs and health workers to track the more cataract cases in community and refer them timely, so that each FCSB has certain specific role to take the cataract patient to the surgical camps and like that. So besides this, we will scale up the surgical camp in the community. So we have planned to scale up 2 or 3 each year in the community to address the backlog. Besides this, we have established our one reviewed our one target and established how can we meet this backlog by scaling up the activities. So that's also an implementation phase. And besides this, we will have a regular monitoring and reporting program in the community that will again provide feedbacks to the service delivery, training and building design and construction to implement the plan and project within timeline. Next slide please. These are given some of the pictures that from community. So you can see the service being delivered in the community, like screening, surgical care from Nuwako districts. Next slide, please. These photographs are from school teachers training that conducted in community, October and Nuwako. Next slide, please. As a part of awareness and advocacy, we have conducted one cycle rally in Bhaktapur district as well as some advocacy level program in Bhaktapur and Nuwako as well. Next slide, please. So this is the very recent photo that we have conducted a memorandum of understanding with Bhaktapur to upgrade the existing community center into a surgical hospital. So these are some of the photographs from local governance agency and from the representatives from Tilganga Institute of Ophthalmology. Next slide. Okay. So seeing up the slide. So Susan, before moving to the question and answer session, I would like our expert to say something about the service delivery mechanism as well as some training and other orientation program. How did we conducted this, and for this I would like to request our Deputy Program Director, Mr. Naveen Kumar Rai, to have his say.
Hi, Susan.
Hi, yeah, that's absolutely fine, thanks.
Okay. So thank you, Ravi. It's a very brief presentation. So I would like to add about our modality of the services. So if you see the output of our activities, so this is the exact figure what we did last 2 years. So we have more challenges to meet our target, the 5 years target. So this is a part of our integrated project in our community. So the service delivery system modality with this program is our model. So the local government and NGO sector is the major stakeholder. So this Nuwako and Bhaktapur district, the one is our urban setup, one is our rural setup. So we are trying to show our modality, which is a sustainable modality from developing situation. Blindness and visual impairment in the community, its major cause of blindness is cataract, and nowadays there are more important emerging issues about visual impairment. So these two areas we are trying to implement a successful model, a sustainable model. Is an integrated approach, and community participations, and government, non-government, and private sectors. So all three stakeholders should take the same ownership from this project. Thank you.
Thank you so much.
Hello, Susan.
Hello.
Similarly, regarding to the infrastructure development and community, our expert would like to say something. Our administrator, deputy administrator here, would like to say something.
Hi, Susan. This is Bhagirat Bania.
Hi.
Yeah, I'd like to say something about infrastructure development. After procuring land from municipality, and we formed a technical group of 2 engineers, myself, Navin Rai, in that group to develop the hospital. First we have to plan the hospital, and because this
It's actually the same 3 people asking lots of questions. That's the same
part of the big hospital of area. So we have provided them our requirement in the eye health requirement. So the first phase we sit 2 times with them in the plan, infrastructure planning. So that is, we again sit with them next week for further development, so that they can make a master plan, and our portion will be in eye health only, in ophthalmic services only. So this is about Bhaktapur. And regarding Nuwakot, we already almost agreed to purchase the land. So the land is a very good area. So maybe next week or after 2 weeks we'll go there again and purchase the land. And similarly we'll do some planning with engineers and some land development. And then after this monsoon we start construction, something like that, after completing all the local formalities with the local government. So it will take another 1 or 2 months, because this is monsoon, we can't do anything. So maybe that will be, we'll start construction around September, something like this. This is all from my side. Thank you.
Thank you so much.
Again, coming to our presentation, Mr. Deveskar, the project officer, would like to share some idea on training and orientation to school teachers and how they are currently functioning.
Hello, Susan. I'm Devesh here.
Hi.
As you see, the target of our project for school children were over 119,000, but till date we only examined around 1,800 children, and most of the schools were breakdown during this earthquake. So for around 8 months we were not able to do any school programs there. So we have revised our targets, and now we have included private schools also, so that there are a huge number of students in the private schools, so that we can meet the target. Before we were using only government schools, and we were training only government school teachers. So they were not doing their work properly due to other businesses also. So now
just to see how she can, if she can see the attendees, or if not, then tell her don't worry, I can see them.
Private school teachers, where the number of schools children are high, so we hope that we can reach our target by the end of the project. Thank you.
Thank you.
Thank you, Susan.
Thank you, Ravi and the team from TIO Nepal. That was a really interesting presentation, and I think what's been interesting for this particular project is some of the work you've had to do kind of since the earthquake, in terms of sort of rebuilding and managing kind of reaching people after that happened, and how you can kind of for this project they're sort of going to have 2 sort of outreach clinics, and how that for that process to happen you've had to have really embed the work you're doing within the government, and have all these sort of meetings and sort of make sure that it really is embedded within the health system. And the other thing that I really like is using the local health workers. So again, you're sort of embedding to sort of track more cataract cases. So again, it's sort of a great way to embed your sort of primary eye care into the primary health care. So thank you so much for that. Okay, so now I'd quite like to take some questions. So quite a few people have sent in some questions anyway. If you do have any questions for either Pratik or Ravi, please put them either in the chat box, or some people have sent sort of the questions directly. We do have quite a few questions actually, so we'll make a start, but whilst they're sort of answering these questions, if there's anything else that you want to see, please do sort of put your questions in the chat box. In the meantime, what I'm going to do is, because we've got quite a few questions, I'm going to sort of group them together, the more popular questions. So there's something around, for Pratik actually, first of all, of around the children that were actually wearing their spectacles. There have been a couple of questions around some of the challenges of getting children to actually wear the spectacles that they've been prescribed with or sort of given. So do you want to talk a little bit more about how, from your project, how many children were sort of wearing the spectacles that they were given, and how you encourage them to wear spectacles a bit more?
Should we put our question, or can we say now?
Let's have this first question to Pratik, and then Ravi, what I'll do is, I think there are some questions for the two of you after this one. So Pratik, are you online still? Okay, I can't hear Pratik, so what I'll do is I'll send him a quick message, and then maybe in the meantime, Ravi, there was a question for both of you around sustainability and how you're planning to kind of sustain these services, and particularly sort of the eye care services to people after the Seeing is Believing project has finished. So Ravi, would you like to answer that question around sustainability and how you're hoping that these services will continue once the Seeing is Believing project finishes?
Okay. About the sustainability, Susan, are you getting?
Yeah, I can hear you clearly.
Yeah. So about the sustainability, management, technical, and financial, these three major areas, how to sustain our program within 5 years' time. So I think we have a program right now in the capacity building, human research, training, infrastructure, and service delivery, and advocacy. These are the major activities to make our program sustain. So we are giving the training from primary school teacher to primary health, female community health volunteers, to our cadre from community, and our ophthalmic assistant and our ophthalmologist for this project will be the big asset of human research. This is number one. Number two, we are creating the demand of our services from the community, the referral system, and by the community volunteers to the local authorities, and other area infrastructure development. We will have more space, more program to increase our services, to improve our services, because that we will have more financial income generating program because of the urban setup in the Bhaktapur. I think paying capacity from our client or service receiver. Then other Nuapur or rural setup, there are more program, not only this SIB project, other local stakeholders we are working together. So I think within 5 years time it can be sustained financially, at least running cost of our center. So the management side, Tilganga itself is a big institutions who are looking after the whole district. So Tilganga is a backbone, huge resources to support
Thank you. And I think so we had a little bit of a technical issue there, but I think we should be able to get Pratik back online now. Pratik, are you able to come back on now? It's like he can't unmute it. It can't be unmuted by him. Oh. Pratik, it seems that it kind of comes on as self-muted. That's what it's saying, and it seems to say that it can't be unmuted by me. So could you try clicking on your it seems that you should be back on now, Pratik. I'm not sure Pratik is hearing us. Pratik, can you hear me? And do you want to test your microphone? It should be on now, so we should be able to hear you. Let's see what, it should be, I think your speaker's unmuted now, Pratik. If you want to try saying something, and let's see if we can hear you. Okay, so in the meantime, while we're trying to get Pratik back online, there were also some other questions for Ravi from TIO. So one of the questions, Ravi, was around do you have any specific interventions that are targeting females in your work?
Yes, Susan. We have a pricing tier. There is a cost for our service. Who are able to pay, they have to pay full charge. There is a subsidized and free of cost. Tired of the cost for services, especially for the community, our program, who are referred by the community program, that is our unit, then we have to consider as for our patients, economical status. There are more female than male from our community program. So we know there female are this highly our prioritized, and children and age, 3 groups. We have a scheme for considering the cost for the quality of services. Thank you.
Great, thanks a lot. Thanks a lot, Ravi, for that. That's really interesting to kind of know how you're sort of ensuring that the services are meeting sort of women at the same level as men as well. Thank you so much. Right, okay, I think we have Pratik back online now. So let me just... Right, Pratik, do we have you now?
Yes, hi, how are you?
Okay,
Sorry
great.
about that.
No, that's fine, that's fine. So, Pratik, so we had a couple of questions for Helen Keller Indonesia. One was around how do you are you finding that when you distribute the spectacles for the children, are they wearing the spectacles? And if they're not wearing them, how are you sort of is that an issue for the project? And how are you kind of encouraging children to wear more spectacles? That was kind of one of the questions. And the other one was around sustainability. So how the project activities will be sustainable at the end of the project. So if you could maybe have a go at answering some of those questions, and then if anyone has any other questions, please do send them across to me, and I'll see if I can find any themes within the questions as well. Thanks.
Sure. So compliance awareness, we did annual surveys. To assess to see what compliance was of wearing glasses, and it was under 50%. So you didn't have children who necessarily, in a lot of times they didn't have them on them. Some of them had broken glasses. but I think that's suboptimal, and I'm not entirely sure how that would compare with other countries or other contexts, but that's certainly low. Now, when we give out the glasses, the refraction opticians, they did provide one-on-one counseling, to help the child use the glasses. And so, but that tended to be a one-off, and so there wasn't perhaps that sustained counseling as you go, because we would just go to the school once over a couple-week period where we would identify the children with the glasses. And so I think that's an opportunity where you can try and figure out how do you have the continual encouragement rather than have the system going on, which I think goes directly into sustainability. And so one of the questions that's always been asked is, when you give these glasses for free, and that's not really sustainable, because we can give away the glasses for free. But actually, two things. Number one is that we hope that by having the glasses that you develop a value system around it, that it includes your accessibility to the learning materials on the board, and then you're more inclined to wear them. But what we've learned is that here, at least in Indonesia, the National Health Insurance System does provide free eyeglasses for children, but that's provided in an ophthalmology science prescription. And so what that means is that a child will have to make it to a district hospital, the district hospital. So I think that those things, it's there, and I think that that's something that we're at least very interested in, is to see that is there a way to thread the loop between the National Health Insurance System, the school-based screening, and refractionists, whether they're at the optical shop or at the primary health center. And I think that could be an opportunity for sustainability. Thanks.
The one around how many children are wearing specs?
Oh yeah, he did. Great. Thanks a lot. Thanks a lot, Pratik. Okay, great. And thank you everyone for sort of sending your questions in. I think we started at about 10 minutes late, so I think we can probably continue for about another 10 minutes or so. So if you have got a burning question, please do send it to me now if you want it answered by the end of this webinar. We've got about 10 more minutes, so please, if you've got a question, send it to me in the next couple of minutes if you want it to be answered. In the meantime, one of the questions that's come up for both Ravi and Pratik is around sort of indicators for your advocacy and your communication activities. So, for example, for your communication activities, obviously at the end of your kind of project you can know how many activities you did as part of the project. But do you have any other kind of indicators in terms of the effectiveness of the activities you've done around kind of communications, letting people know about the services, convincing people to go for the services? What kind of sort of indicators, or how do you know these activities have been effective? So if we start with Ravi, if you want to answer first, and then Pratik second.
Hello. Concerned to the indicators of efficacy in REC, we conduct regular stakeholders meeting where multiple stakeholders participate in the meeting, like participants from district education office, district health offices, other Red Cross, other local governing agencies. Similarly, we also conduct district project advisory committee meeting, and similarly these meetings as well as regular visits are also conducted from Social Welfare Council, governing agency from the ministry's line of ministry. And besides this, we also conduct regular radio programs at the community which disseminate the eye health information materials and communication at the communities. So these are the few indicators that measures how we reach to the community. During the activities like Worksite Day and radio programs. We also distribute the pamphlets and other various materials that directly reach to the community. These illustrated pictures and informations also helps the community people to aware. Besides this, we also have a case study and story, audio-visual case studies that indicates that how we are getting into the community with information and communication materials. Thank you.
Thanks a lot, Ravi. Pratik. Oh, sorry, go ahead.
Just to add on that, basically it's 2 meetings that we call stakeholder meeting. That is a sort of social audit where we invite all the government officials, chief of government officials, and member of political parties, then journalists, and many people. We invite them and so we present them our all the activities. That is we call this is a sort of social audit, and there is a mandatory is a DPAC meeting. That is DPAC is District Project Advisory meeting. That is mandatory. We have to conduct once in the year. No, it's mandatory by Social Welfare Council. We do regularly both meetings. Thank you.
Thank you. Okay, Pratik.
That's an interesting question.
Oh, sorry, Pratik, we can't hear you very well actually. Would you be able to try and sit a bit closer to the microphone maybe?
Sure. Can you hear me now? Okay.
Now perfect.
Okay. Sorry about that. We collected information on the number of people that received the messages, but we weren't collecting intermittent or routine knowledge, attitude, practices survey that understood what the impacts were of the, let's say, the messages. And we didn't do a community-based or population-based survey to assess to see what the changes were over time of a specific communications package. Thanks.
Okay, great. Thanks a lot both for giving some feedback around sort of the advocacy and communication activities. And obviously it seems that from both of your sort of projects, having that kind of close relationship with the government and working with them, particularly as you were mentioning in Nepal, having these kind of stakeholder meetings is really important to kind of embedding the work and getting that support from the government. So that's really great to hear. All right then, we've just got time for one final question. So there was something around how are you strengthening how do you feel you're kind of specifically strengthening the referral system? So for example, the teacher for the Helen Keller project, the teachers that are screening the children, or with the idea that you'll be then hopefully referring them to the primary healthcare centres sort of in the long term, or for Ravi around if you're sort of finding the patients in the local communities, how you kind of ensuring that they're referred up to the hospital. So do you want to talk a little bit just finally on your different referral pathways and how you're kind of strengthening those? And again, if we maybe start with Ravi again and then end on Pratik, and then I think we'll probably end it there.
Okay, Suzanne. For the referral system, our female community health volunteers and school teachers are trained to examine basic eye diseases also. So if they see any deformities in the eye, they first refer to the community eye center, where our ophthalmic assistant, ophthalmic officers look the patient under a street lamp and they examine them, they do refraction, they dilate the eye and examine all the things. And if they are able to treat from there, they are treated from there, and if not, then again they are referred to the Tilganga Eye Center, which is our center of excellence, where we have got some specialty facilities in different subspecialties. So in this way we have a referral system, and we provide one referral slip to the teachers and FCSB, from where they refer by writing their name, and they are given a special priority in our community eye center and Tilganga Eye Center. Thank you.
Great, thanks a lot. And then finally, Pratik.
Thanks, Susan. So in terms of referrals, we provided specific information to tell people where to go once they've been referred. We've provided referral slips with detailed information. So I mean, I think that we've done some of those things. The question is that we are looking to see how can we improve, because ideally we want 100% of referral compliance, and we're not there yet. So we're still looking to see if there are ways, whether it's through mobile phone applications or whether there's some different patient education materials that we can do to improve referral uptake. Thanks.
Great, thanks a lot, Pratik. And actually, I'm just thinking, and I know that in some of our previous Seeing is Believing newsletters, there's also been people writing some articles on things like referrals, and you mentioning the sort of sending text messages and SMS messages to sort of increase referral, and that there are definitely some articles that have done that. I think Sight Savers in Pakistan have done that. So it's worth kind of having a look on the Seeing is Believing section of the IAPB website and having a look at some of the previous sort of articles people have written on sort of variety of these kind of areas actually, so that would be really interesting. That's all for today. So I just want to end by saying thank you so much to our panelists. So thank you to Sally for doing the introduction at the beginning. Thank you to Ravi and the team in Nepal. Thank you for Pratik, particularly for persevering throughout all of the technology challenges. So thank you very much to you both. Really appreciated you doing the presentations, and I feel that sort of I've also really gained from listening to you today, that kind of really insight on a specific area of how your projects are strengthening the eye health systems in your country. So thank you both very much for doing the presentations and sort of sharing your knowledge and your learning with us all. I really appreciate it. Thank you so much.
And we also appreciate from Tilganga to provide such sharing and learning platform, Susan. Thank you very much.
Thank you.
This was fun.
Great, thanks a lot. And also thank you to all of the attendees and everyone who's signed in today. I will be sending out a survey, like a sort of SurveyMonkey survey in the next week or so. So if you did find this webinar interesting and informative and you'd like to see more of them in the future, then please email me or fill out the survey, and then it will be a definite possibility. So if you are interested in having more of these in the future, then do let me know, and in particular if you're interested in presenting, then also let me know. So thanks a lot everyone, and look forward to seeing you again sometime.
Thanks.
Bye all.